My name is Niesvizky. I'm the director of the myeloma program and an associate professor of clinical medicine at the Weill Medical College of Cornell University and New York Presbyterian Hospital. We are here in the American Society of Hematology meeting in Orlando, Florida, where we presented our final analysis of our clinical trial, Revlmid, dexamethasone, and Viaxin, the BIRD trial, for patients with untreated multiple myeloma or as first-line therapy. In this clinical trial, we treated any patient with multiple myeloma with symptomatic disease with either stage 2 or stage 3 who require therapy with Revlmid at 25 milligrams daily for 21 days and a week break, followed by clarithromycin, which is Viaxin, 500 milligrams PO BID, all through the treatment of the protocol, and dexamethasone at 40 milligrams once a week. With this regimen, we established very strict rules of dose reduction depending on toxicity. Specifically, any patient who had myelosuppression, that is low white count, low platelets, or anemia, required dose reduction depending on the degree of myelosuppression. For instance, if you had low white count, the first dose reduction was the requirement of using G-CSF or pegylated G-CSF. Also, we established transfusions as a parameter for those reductions. The results are very impressive in that in an intent to treat analysis, that is, we are using as a denominator all the patients registered. We have accrued 68 patients, and out of those, more than 85% had an objective response, more than a partial response, meaning more than 50% drop on the paraprotein. Of those, and using the more stringent criteria recently published, we've seen that more than 60% of the patients have achieved more than a very good partial remission, which means more than 90% drop on the paraprotein. The toxicities, of course, were present in about 40% of the patients, specifically the myelosuppression, which was easily managed by dose reductions. What was interesting, however, that every patient that required dose reduction, meaning the use of growth factors such as G-CSF or transfusions thereafter, were those patients who had a suboptimal kidney function, indicating a creatinine of 1.4 or more, or a creatinine clearance of 40 cc's per hour or less. Those patients who did not have that kidney abnormalities, only 1 or 2 required dose reduction, indicating that kidney dysfunction is an important factor in determining the appropriate dose for these patients. We conclude that with this clinical trial, with a combination called the BIRD, we can achieve high remission rates, and it can be used for both patients who go into an autologous stem cell transplant or those patients who are not candidates. With modest dose reductions, this therapy can be given in a chronic fashion, and we have learned that renal insufficiency is a major corporate on the development of low white count or low platelets. We plan to further this clinical trial by using new combinations such as thalidomide or perhaps bortezomib. Currently, we are combining bortezomib with dexamethasone in those patients who did not achieve a partial remission after the BIRD clinical trial.